hours. Um, they pretty much did the whole workup, you know, and then they had a transport company come and pick me up and take me to Wake Med. So this whole time, you know, back to the mag, they started giving me the mag. I instantly got hot. You know, everybody else, I was freezing them out of my room because I had to have it so cold. I mean, I just thought it was the funniest thing. And yet still I'm thinking there's no way I'm going to have this baby in the next 72 hours. Like, we're going to do all this and then I'm going to get sent home and I'm going to be on bed rest. You know, this is still in my mind playing around. I've got all kinds of family coming up there, you know, whatever. So I get shipped to Wake Med, fantastic hospital. They're great in obstetrics. They couldn't have picked a better hospital. It was fantastic. They treated us amazingly. And every bit of care there was just great. So anyway, long story short, I went there on a Thursday night. And of course they continued with blood, I got another steroid shot after 12 hours for the baby's lungs. I was still on MAG. I stayed on a MAG drip the entire time that I was there. Like from Thursday to Saturday I stayed on a MAG drip. I'm sorry, Thursday to Sunday. And it just kind of, if you've never heard anybody talk about MAG brain, it's a real true thing. It is absolutely real. I remember a lot of stuff that happened, but I don't quite remember it in the detail that my husband does. I mean, he could tell you every number, every single time I check my platelets, he can tell you everything. And I don't remember all of that. I remember being able to see people for the first half, and then the last half, I couldn't see anything. I could hear everybody, but I was so out of it. And that actually helped a lot with pain too. That's why I say the best worst drug. The worst part, it makes you hot. MAG brain sets in. You don't remember anything. You can barely see, you know, barely hold your eyes open. But the best part was I do believe that it actually helped with some of the pain, and even after my delivery, some of that pain from the cesarean. So, during this time, you know, they said they tried to induce me, tried to, you know, get me started so that I could actually finish the process myself. So it was a very severe form of help, but at the same time they were able to also give me the chance to try and do it on my own without having to have a cesarean. So when it got to the point that none of it was working, of course the cesarean option had to be taken. Did that, I had to stay on MAG after that for another 24 hours. So even after that cesarean, which went great, after that cesarean I couldn't see my child for another 24 hours because I had to completely come off the MAG. I had to eat, you know, I had to do all of these things before I could actually go anywhere and leave that room. One of the things about the platelet count that I actually learned a lot about after the fact, I didn't realize during, but I learned about after, is that low platelet count. If it's lower than 100,000, and some doctors will say 80, they will not give you an epidural. So at that point, what I didn't realize is without that epidural, my only other option they were going to give me was to locally numb me and do the cesarean. Really glad it didn't work out that way. But my platelet count, finally they got it up to 80,000. And the doctor that was doing my epidural, he was good with that. Come in, did the epidural, had to actually push the meds through twice. It didn't work the first time. But after that, pretty much went as said. Now with the hypertension that I had, I actually stayed, I was admitted to the hospital after I had her. So after Sunday, I was actually admitted for a week after that so they could try and control my blood pressure. They were doing everything they could to control it, using different types of medication. Some worked, some didn't. At one point they were working too well, so we kind of had that battle for the first week. Once it was controlled, by the end of the week, I was released and of course able to go stay with my daughter in NICU. Side note, they have a fantastic NICU and their nurses are just amazing. So, it's one thing to keep in mind, especially with emergencies like these. If you can get them to the facility, then somewhere that has a NICU, and especially a high-rated NICU, is a fantastic place to be. I could have easily delivered at a local facility, however, they would not have kept me there. It would have been a delivery and both of us get sent out by 2 separate ways. So just something to keep in mind. That's my story with HELP, but it is really good information if you have the chance to do, if you don't know anything about it and you have the chance to do research on it, it's actually really good to know. So, all right, I have a video that I would like to show you. If you'll just bear with me for a moment.
I was told that there was no help for me, that ain't no difference where I went.
Preeclampsia is a disorder that only happens in pregnant women, and it happens after 20 weeks gestation, and in some cases develops up to 6 weeks after delivery. Preeclampsia causes new-onset hypertension and proteinuria, which is a marker of kidney damage, and can also cause damage to other organs, like the brain and the liver. There can be a wide range of symptoms. For some women, there might be no symptoms, or only mild ones, whereas for others, it can turn into a life-threatening illness. If a woman with preeclampsia develops seizures, she's then said to have eclampsia. Preeclampsia tends to happen more often during a first pregnancy, in pregnancies with multiple gestations, or in mothers 35 years or older. Other risk factors include having hypertension, diabetes, obesity, or a family history of preeclampsia. Alright, but why do these changes happen in preeclampsia and eclampsia? Well, the exact cause is unclear, but a key pathophysiologic feature is the development of an abnormal placenta. Normally, during pregnancy, the spiral arteries dilate to 5 to 10 times their normal size and develop into large uteroplacental arteries that can deliver large quantities of blood to the developing fetus. In preeclampsia, these uteroplacental arteries become fibrous, causing them to narrow, which means less blood gets to the placenta. A poorly perfused placenta can lead to intrauterine growth restriction and even fetal death in severe cases. This hypoperfused placenta starts releasing pro-inflammatory proteins. These then get into the mother's circulation and cause the endothelial cells that line her blood vessels to become dysfunctional. Endothelial cell dysfunction causes vasoconstriction, or narrowing of the blood vessels, and also affects the kidneys in a way that makes them retain more salt, both of which results in hypertension. When diagnosing preeclampsia, hypertension is defined as a systolic blood pressure of 140 millimeters of mercury or greater, or diastolic blood pressure of 90 millimeters of mercury or greater. In severe preeclampsia, systolic blood pressure can be 160 millimeters of mercury or greater, and diastolic pressure can be 110 millimeters of mercury or greater. These extreme blood pressures can lead to a hemorrhagic stroke or placental abruption, which is when the placenta detaches prematurely from the uterine wall. Now, there can also be local areas of vasospasm, which means that less blood might reach certain parts of the body. For example, reduced blood flow to the kidneys, which are particularly susceptible, can cause glomerular damage, leading to oliguria, which is abnormally low amounts of urine, as well as proteinuria. Normally, the glomeruli of the kidney do a pretty good job of preventing protein from spilling into the urine. So proteinuria can be a sign of glomerular damage, and is classically seen in preeclampsia. Reduced blood flow to the retina can cause blurred vision, the sensation of seeing flashing lights, and the development of a scotoma. A scotoma is when a small part of the visual field has slightly worse visual acuity, which is kind of like having a blurry spot on your computer monitor. Reduced blood flow to the liver can cause severe liver injury and swelling, which can cause an elevation in liver enzymes and stretches out the capsule around the liver. Stretching of the liver capsule typically causes right upper quadrant pain, or epigastric pain, which is one of the cardinal symptoms of severe preeclampsia. Endothelial cell injury also leads to the formation of lots of tiny thrombi in the microvasculature, which is a process that uses up massive amounts of platelets. Having all these tiny blood clots in the blood is a little like having dozens of boulders in the middle of a fast-moving river. It becomes treacherous for red blood cells to navigate through, and before long they slam up against a clot and get destroyed, which is a process called hemolysis. Together these make up the HELP syndrome, H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. HELP syndrome develops in about 10 to 20% of women with severe preeclampsia or eclampsia. Finally, endothelial injury increases vascular permeability, which is when water is allowed to slip out of blood vessels between neighboring endothelial cells and get into the tissues. Because there's also a loss of protein from the blood due to the proteinuria, even more fluid moves from the blood vessels into the tissues. And this causes generalized edema, which is often seen in the legs, the face, and the hands, pulmonary edema, which can cause cough and shortness of breath, and cerebral edema, which can cause headache, confusion, and seizures. And these seizures are what define the onset of eclampsia. Because all the problems of preeclampsia and eclampsia stem from placental dysfunction, the ultimate treatment is delivery of the fetus in placenta. The decision to induce delivery depends heavily on the gestational age of the fetus, as well as the severity of the disease and how it's affecting both maternal and fetal health. If the onset of symptoms comes after delivery, then the goal is to manage the symptoms, which slowly subside on their own. Additional measures are aimed at managing any end organ damage by offering supplemental oxygen, as well as medication to manage seizures and other complications like stroke or placental abruption. Alright, as a quick recap, preeclampsia is a disorder that happens after 20 weeks gestation and up to 6 weeks following delivery. It's defined by a new onset of hypertension and proteinuria, but can affect a lot of organs, particularly the kidneys, eyes, liver, and brain. Eclampsia is diagnosed when a patient with preeclampsia develops seizures. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Okay. Alright guys, so that was just a little short video that I found to be very interesting. You can explain it much better than I can. Ectopic pregnancy. When a fertilized egg implants outside the uterus, the egg cannot survive on the outside. If left to grow, it can cause damage to nearby organs and cause life-threatening blood loss. 6 to 16% of pregnant women who present in an ED in the first trimester have an ectopic pregnancy. 4 to 10% of all pregnancy-related deaths, it's the cause of 4 to 10% of all pregnancy-related deaths, and it's the leading cause of first trimester death maternally. Signs and symptoms: pain in the abdomen, pelvis, or side part of the body, abnormal vaginal bleeding, and abdominal cramping. Treatment consists of course, is not going to be done pre-hospitaling. It's going to be done in the hospital. It consists of medication to stop the cell growth and dissolve the existing cells. And then, of course, surgery to remove it. So I don't know if you can see it down here, but you have the uterus and you have an ectopic pregnancy. It's got two different diagrams of where it could be. And right here on the side here, it's outside of the uterus. So that's not going to be a good quality of life. It could cause maternal death, and it's going to have to be removed. Again, the correct facility for this, most appropriate choice. Nuchal cord. When the baby has their umbilical cord wrapped around the neck, it can happen during pregnancy, labor, or delivery of the baby. Most commonly diagnosed by an ultrasound, and that's if you have, if you actually have the care during your pregnancy, it can be diagnosed this way. Now, there are times when you may deliver a baby and you're going to figure it out when that baby's head comes out, the cord's wrapped around it. That's okay. If delivery is imminent, the provider can attempt to get 2 fingers between the cord and the baby's neck. You can see if the cord can be slipped around the baby's head. But if it's tight, do not attempt to pull on the cord. You can risk damaging the cord. You could risk pulling it apart, and then you could risk hemorrhage for that baby and the mother. Breech presentation. So there are 3 different types of breech presentation. Complete breech, when both of the baby's knees are bent and its feet and bottom are closest to the birth canal. That's going to be in this first picture right here. Right here. Incomplete breech, when one of the baby's knees is bent and his foot and bottom are closest to the birth canal. This one. And then the last one, frank breech, when the baby's legs are folded flat up against his head and his bottom is closest to the birth canal. So, breech births, statistically, 3% of presentations will be breech. Doesn't sound like that much. It puts the fetus at an increased risk of trauma that they can do to themselves from being stuck in the canal, anoxia, and prolapsed cord. Breech babies can be delivered